Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to thank Dr. Christina Mara for coming back to do another talk for us. Dr. Mara is professor of neurology and ID here and one of our neuro ID experts, and she's going to talk to us about a rather controversial topic today. So I'll just turn it over to Christina.
Okay. So I'm going to talk about central nervous system penetration of antiretrovirals. Does it matter? And the answer is yes, but maybe not in the way that you think. So we'll start by talking about HIV-associated neurocognitive disorders, because we need to be on the same page here for what I'm going to tell you about. So there are three categories of HAND: asymptomatic neurocognitive impairment, or ANI, mild neurocognitive disorder, or MND, and HIV-associated dementia, which I call HAD. And the diagnosis is based on results of neuropsychological testing and an assessment of everyday functioning. So for ANI and MND, you have to have at least two areas of mild impairment, two domains in which you have mild impairment, two neurocognitive domains. The difference between the two is that for ANI, there's no negative effect on everyday functioning. So it's important to remember that those people are equally impaired with regard to their performance on the tests. They just don't have complaints, and maybe they don't have complaints because their life is not very demanding. So keep that in mind because it's an area of controversy. And then for dementia, patients have at least moderate impairment in two or more neurocognitive domains and two types of evidence of major functional decline. These can't be attributable to confounding conditions, and there are some conditions in which you would not be able to make a diagnosis of HAND. For example, a person with a serious head injury who never returns to baseline function, a person with a serious learning disability who's never been able to live independently, people who have really severe psychiatric disease. Those are the kind of confoundings in which you just couldn't make a diagnosis of HAND. So how common is it? These are the data from Charter. Charter is a multi-center observational study. We have a site here. This study looked at the baseline performance of about 1,500 participants who underwent a structured psychiatric interview, a comprehensive substance abuse history, a neuromedical assessment that included a spinal tap, and a comprehensive neurocognitive battery. The group had high ARV use, but they weren't all suppressed. So 71% were currently using antiretrovirals, 14 used them only in the past, and 15 were antiretroviral naive. And these are the results. Of the 1,550 baseline assessments, 239 patients had such severe confounders they couldn't be assessed. Of the remaining about 1,300, 33% had NCI, 12% had MND, and 2% had HAD. So just short of 50% were neurocognitively impaired. This is a study that was done by an Italian group. It's a convenient sample of 100 individuals, and they estimated that 50% had ANI, 17% MND, and 2% HAD. So actually pretty similar to what was seen in Charter. So in terms of the epidemiology, there's a high prevalence of HAND, but most of it is asymptomatic. And then this is a nice study that was done from a Canadian group looking at patients in a big clinic. And they found that HAND increases the risk of death. So if you look at the graph, so here's survival on the y-axis by years since HIV diagnosis on the x-axis, without HAND in the solid line, with HAND in the dotted line. HAND increased the hazard or the risk of death by about threefold. And in their study, and a lot of other studies are in agreement, predictors of HAND were lower current and particularly lower nadir CD4, and I want you to remember that. Shorter duration of antiretroviral treatment and shorter duration of being undetectable. What causes HAND? Well, before we had potent antiretroviral therapy, or combination antiretroviral therapy is the acronym I'm using here, or CART, we thought that HIV-associated dementia was due to productive infection of the CNS, probably in perivascular macrophages and maybe in microglia, which are the resident macrophages of the brain. How might people who have well-controlled HIV have HAND now? And some of the thinking is that it's due to drug resistance within the CNS. So we're not effectively treating CNS virus, maybe because of poor penetration, the topic we're discussing today, maybe because of poor adherence. There may be a legacy effect, so previous injury has caused cognitive impairment. It doesn't progress when the patient gets on good antiretroviral therapy, but it doesn't go away. Comorbidities are probably playing a larger and larger part. So think about aging, vascular disease, co-infections, and drug abuse. And then the issue of combination antiretroviral therapy toxicities is something we'll touch on here that's becoming more of a concern, although it's still pretty controversial. So in terms of estimating drug penetration, there are two versions of the CPE rank, CNS Drug Penetration Effectiveness. This was devised by Scott Latender at UCSD. This is the 2008 ranking system. 1 is the best and 0 is the worst. You can see that the drugs with the very high penetration in this system, zidovudine, we still use some of that, nevirapine, maybe some people get Kaletra. The lowest ones, tenofovir, really common part of many people's regimens, and then the old protease inhibitors, as well as enfuvirtide, and then these were in the middle. Scott updated this in 2010 to a 4 category system, with 4 being the highest, 1 being the lowest. We don't use much of the very high ones, but notice zidovudine and nevirapine, things that some people still get. The ones with the lowest, tenofovir, enfuvirtide, nelfinavir. And then a lot of the drugs we use have pretty good penetration. So people are still getting abacavir, emtricitabine, efavirenz, boosted darunavir. And then notice that maraviroc, raltegravir is still here. Dolutegravir will probably go here. It's thought to be a little bit better than raltegravir, but he hasn't coded it yet. These graphs are taken from one of Scott's publications. So the one on the left, looking at the proportion of patients with detectable CSF viral load on the y-axis by the CPE score. And the CPE score for a regimen is just the sum of the individual parts. And you can see that as the CPE score goes up, fewer patients have detectable CSF virus. Not surprising, since that's actually taken into account in devising the CPE score. He also looked at dichotomizing by what he thought was a low and a high CPE. So a CPE of 7 or less, about 47% had detectable virus in CSF. A CPE of above 7, 36% had detectable virus in CSF. And this was using a lower limit of copy number of 2 copies per ml. So you can see a significant difference. So I think most people would agree higher CPE better suppresses CSF virus. But whether that translates into a clinical benefit is much less well established. So I'm going to show you 2 studies. This first study shows you that higher CPE improves cognition. So a study by Lucette Sisik, who's now back in Australia, 37 neurocognitively impaired individuals based on 6-test battery. They were untreated or failing their antiretrovirals. Their mean CD4 was around 200. And she found that people who had a lower baseline neuropsych performance improved more. And that was, the thinking was just they had more room to improve. And when their CPE was above 2 using the old system, they were more likely to improve. But you can contrast that with a study that we did in the AIDS clinical trials group, where we showed that higher CPE conferred cognitive worsening. So this was 26 neurocognitively impaired individuals based on a 4-test battery. They also were untreated or failing their antiretrovirals. They had more advanced disease. This is a median and not a mean, but their median was 94. And we chose them to have very advanced disease. Did a fancy GEE model to look at their performance over time. So we found that higher entry NPZ4, that's the composite measure of neurocognitive performance, conveyed improvement, the opposite of what Lucette Sisik found. People who took more antiretrovirals did poorer over the course of the study with a statistically significant p-value. And importantly, people whose CPE was at or above 2 using the old system did significantly worse over the course of the study, dropping by a full z-score, which would be clinically significant, would be pretty obvious to you. A half a z-score is clinically relevant. So a study showed that CPE improves cognition, a study showing you that CPE worsens cognition. So how do you put that together? Well, first of all, the studies, and there are other studies, I just showed you 2 examples. The designs of the different studies are different, cross-sectional versus longitudinal. Virtually all but one I'll show you have been observational. And you might have heard us talking about this in the beginning. a bias in selection of CART regimens. If patients who have cognitive complaints get a regimen with a higher CPE, that might look like CPE is bad for you. So confounding my indication. Inclusion and exclusion criteria differ in the studies. The definition of impairment differs. People use different neurocognitive batteries. And importantly, there are population differences. And remember, I talked about Nader CD4 being really important as a predictor of dementia, and then how people handle comorbidities. So we've all said we need a randomized clinical trial. So the UCSD group tried to do one, a trial of neuro-targeted CART for hand. It was multi-site randomized controlled. People had hand as defined in that table I showed you in the beginning. They were initiating or changing their antiretroviral therapy, and they were randomized, and I won't go through the details, but it was complicated, to a CNS-targeted regimen versus a not CNS-targeted regimen. And the CNS-targeted regimen had a 2008 CPE median of 2.5 versus 1 in the non-CNS targeted group. The primary outcome was change in neuropsychological test performance at 16 weeks. Secondarily was the proportion with virologic suppression in plasma and CSF. They were only able to enroll 59 patients over about a 5-year period, and they could only do the intention to treat analysis on 49 of them. Although the results didn't meet their futility criteria for stopping, the DSMB stopped the study because of slow recruitment. Their findings are shown in this graph. So this is adjusted change in GDS, which is a composite measure of neurocognitive functioning, 0.5 or, it would be this way, 0.5 or less or greater is worse. So improvement is down on this graph. CNS targeted versus not CNS targeted, and although the CNS targeted group did improve more, it wasn't statistically significant. You can see the p-value is 0.39. But there are caveats you need to take into account when you think about this study. First of all, accrual was incomplete. And the other thing is that the follow-up was really short. They went to 16 weeks. That Lucette-Sasic study I showed you followed people and showed that they continued to improve cognitively over at least 36 weeks after changing their regimen. So it may simply have not been long enough. But there were also baseline differences in the CNS-targeted group. They had a lower Nader CD4. They had more hepatitis C. They had a trend toward receiving more antiretrovirals and a trend toward poor plasma suppression. And then they raised the question, which I raised earlier, is CNS-targeted CART neurotoxic? Maybe we didn't see what we expected because CNS-targeted CART actually makes you worse. This is a study done in the ACTG a long time ago. This is a neurologic sub-study of a study in which patients stopped their therapy. So 167 individuals with pretty high CD4s, median of 436. For some reason, I don't know why they used this HIV RNA cutoff. They had to have less than 55,000 copies per mil. They had to be on at least 2 antiretrovirals for at least 6 months. And they stopped them, and they could restart them at the discretion of the investigator. So this graph shows you a mean neuropsychological summary score with up being better and weeks from antiretroviral discontinuation on the x-axis. And these people got continuously better over the weeks after stopping their antiretrovirals. And they could not make this go away by including covariates. So it's suggesting these people got better. And then this is from the UNC group looking at in vitro neuronal loss due to combination antiretroviral therapy regimens. So there are a bunch of combinations here that you might use, and they tried to emulate the concentrations you would see in blood and CSF. Actually, I think it was in CSF. So I guess this is efavirenz and Truvada, atazanavir and ritonavir, Truvada, and so forth, compared to the control. And many of these combinations showed significant neuronal loss compared to the control. So I think that there are some precedents that antiretrovirals can be toxic. And Scott Latender, going back to the inventor of the CPE system, has sort of conceptualized it this way. So risk of neurocognitive impairment on the y-axis with up being more, antiretroviral drug concentration in the CNS on the x-axis. So you get, at some point, you're too low. So when the concentration in your CNS is too low, you get damage from uncontrolled HIV replication and maybe immune activation, and your risk of neurocognitive impairment is high. When you get to this sort of sweet spot where the concentration in CNS is optimal, your risk for cognitive impairment is low, But at some point, you get to a neurotoxicity threshold. The concentration is so high that you, again, have risk of neurocognitive impairment. And do we have data to support that? And yes, this is from Charter. So this is a classification and regression tree analysis of 70 observations in CSF looking at efavirenz concentrations. So this is just an example. The first cutoff that they came up with is the concentration of efavirenz in CSF at or above 6.6, at or above 6.6. When it wasn't, 3/4 of the individuals were neurocognitively impaired. Okay, so now we say, okay, what if it was above at or above 6.6? What if it was even higher, at or above 13.3? Again, about 3/4 are neurocognitively impaired. So too little, too much. In the middle, between the 6.6 and the 13.3 cutoff, 60% of people were neurocognitively normal. So that's the kind of data that's used to sort of support this conceptualization. The other thing I think is that there may be factors that move this neurotoxicity threshold to the left, to lower antiretroviral concentrations. And this is my opinion, and I'll show you some data that I think supports it. And the things that I think might do that are age, drug abuse, prior CNS injury. And I think this is a good example of how age might play into that. This is, again, taken from the Charter data. So here we're looking at efavirenz concentration on the y-axis, by age on the x-axis, plasma in red or orange, whatever color that is, and CSF in blue. And you can see that over the age range, plasma efavirenz goes up a little bit. But look what happens in CSF. It's pretty stable until you get to be about 53. And then there's this sharp inflection, suggesting that age may increase the drug concentrations in CSF. Maybe that's a reason why older people might be more susceptible to the neurotoxic effects of antiretrovirals. So I thought I'd summarize with a patient I saw last Friday who I'm really suffering with. So this is a 53-year-old MSM who's been HIV infected since 1998. His nadir CD4 is 4, and he was sent to me by country doctor, and he is the most profoundly demented patient I have seen in years. But his CD4 is 600, his plasma is well controlled, and he's on a pretty high penetrant regimen, nevirapine and Truvada, which has a revised CPE of 8. So I'm thinking what to do. So I checked metabolic abnormalities, he doesn't have any, and I've imaged him, and he's got white matter disease. So I'll move over to this, and then I'll come to what I think I'm going to do. So I think that these data tell you that CNS penetration does matter, but that it can be helpful or hurtful. And it's probably patient-dependent, and that we lack the tools to decide who goes which way. And one thing I've wondered about is whether we should measure CSF drug concentrations. So I think what I'm going to do in this guy is I'm going to tap him and be sure that he doesn't have detectable virus in CSF. Because he has detectable virus in CSF, that's a whole other story. And if he does, I can send virus for resistance testing, and I can recommend a change in his regimen. But if his CSF virus is suppressed, should I measure drug concentrations, or can I measure drug concentrations? And would that be worth doing? Because maybe I'm actually hurting him with this nevirapine Truvada regimen.